Hi, good morning. Welcome to the Steps Forward Innovation Academy. My name is Laura Fritchie, and I'm a project administrator for the digital health team here at the AMA. Today, we're joined by 4 excellent presenters, all sharing various perspectives on how to think about and approach human factor in solving problems and modeling successful collaborations among people, technology, and institutions. Our agenda today will kick off with a welcome and introductions, and then we'll move into defining the problem, where we'll hear these different unique perspectives from each of our presenters. We'll hear from primary care physician and educator, patient and family care partner, informaticist and educator, and human factors engineer perspectives. We'll then move into practical problem solving, applying human-centered design principles to the inbox. And if there's time for Q&A, we'll move to that, and then we'll close. If you'd like to learn more about the STEPS program or find additional content, I welcome you to scan the QR code for more information. For a little background to the program, Steps Forward offer a variety of playbooks, toolkits, videos, podcasts, templates, and other resources that work to provide physician-developed strategies to addressing common challenges in medicine and ways to inform practice. This is our quick disclaimer that I'll hold for a second. And now I'm excited to introduce our speakers today. I'll be sharing a high-level intro as I'll be letting each speaker share a little bit more about themselves and the perspectives they bring to today's discussion during each of their sections. We're joined by Dr. Elizabeth Toll, Professor of Pediatrics and Medicine, Clinical Educator at the Warren Albert Medical School of Brown University. Lisa Danielpour, Patient and Family Advocate, Internal Communications Manager at Case Western Reserve University School of Medicine. Dr. William Hersh, Professor at the Department of Medical Informatics and Clinical Epidemiology at Oregon Health and Science University, and Dr. April Savoy, Assistant Professor of Industrial Engineering at Purdue University. And to kick off, I'll pass it to Dr. Toll.
Well, thank you, and hello, everyone. It's an honor to be here. My name is Betsy Toll. I use she, her pronouns, and I bring the perspective of a primary care physician trained in combined internal medicine pediatrics. I've spent most of my career at Brown University, where I've had my own multi-generational practice and taught primary care to residents and medical students. For some context, the 4 of us have gotten to know each other through an informal group whose mission is to prioritize and promote human relationships in healthcare, supported by digital technology and data. We are a diverse, multidisciplinary group of patients, clinicians, and other professionals from around the United States and 7 other countries. And these many perspectives, experiences, and imaginings offer a rich forum for understanding and problem solving. We started in 2017 with a conference which produced a consensus statement, followed by a virtual conference during the pandemic year, and a live conference in 2022, and the conversation continues. So we've identified 7 themes which we believe are a vision for a healthcare system with human relationships at the hub and digital technologies in a respectful, supportive role. Excellent healthcare means reaching all communities and people, and we must also welcome all people from all communities with opportunities for work and advancement in our systems. We need technology and systems that work for the real humans who will be using them. Excellent healthcare and tech requires education, not just about using the technology, but also applying the technology in clinical settings. The workforce of the well-being of our workforce is essential to our work. And while self-care is important, the responsibility for our workforce well-being belongs with the systems and institutions where we work. So we need to be working with their leaders, legislators, and regulators to keep the focus on people. And finally, our digital technologies are vacuuming up enormous amounts of patient data, and we need to be managing this information ethically. So today, we're taking on design. So why does this even matter? Well, medicine is about people and connecting them together to help one another, not, speaking metaphorically, to confirm their dates of birth. And yet, over the past generation, United States healthcare has moved from relationship-based care towards transactional care, where traditionally patients and physicians developed relationships, built a shared history, which was highly relevant to their diagnoses and their care. But increasingly, healthcare is influenced by corporate insurance and regulatory culture, where any provider, so insulting, can see any customer or member, how disrespectful, using templates and algorithms to produce units of care, kind of like deploying rental cars under GPS. And this, of course, has produced a growing burden of administrative and regulatory tasks. And of course, our EHRs and other digital technologies are present in our days, which has added both strengths and challenges. So patients, even kids, can often feel left behind when their practitioners are focused on computers rather than them. And our practitioners often feel scattered, wanting to give their full attention to their patients, but feeling they need to give attention to the computer, which is demanding input. It's a tug of war, kind of like doctoring while texting. Charting has become an overwhelming Sisyphean task, although we're getting better with the Affordable Care Act, with accountable care organizations, and also ambient listening. And the EHR inbox, which we'll address today, the Hydra, cut one task off and 9 more appear. This is enormously emotionally damaging. It's hard to get patients what they need. We're rushed in visits, and yet we carry the legal liability. There are ethical concerns like keeping patient confidentiality. We feel we're spending time on the wrong work. We've lost autonomy, and we're constantly being scolded by the middle managers in our institutions. And of course, the divisive political climate of our society has snuck in the form of patient aggression and misinformation. And yet, if we ask patients and practitioners what they want, it's that deep work of doctoring, strong relationships built on connection and trust and undivided attention and the laying on of hands. People who will take time to connect and explore a problem deeply, assemble the information, and solve it. But we also want practitioners who are current in science and skilled in digital technology, who have manageable workloads. Solutions lie in new relationship paradigms. Gone are the days of Norman Rockwell. Relationships now include the whole healthcare team with the patient and family on that team. And we can bring others into the visit with telehealth, family members, interpreters, consulting colleagues, and so forth. And our EHR is actually functioning as a team member as well, helping with communication, education, and information exchange. And when technology functions as a support, it bridges and strengthens relationships. Trust is changing in this brave new world. Traditionally, trust was between a patient and a physician and sometimes a doll. But now, trust involves all these technologies. And while some of our invasive and imaging and lab machines are regulated, the rest of the stuff is not. Not computers, not software, not wearables, smartphone applications, internet, and generative AI barreling down the pike. All this is changing paradigms of confidentiality, privacy, and security, and asking us what is happening to our patients' all precious story. Many physicians, especially primary care docs, really have 3 jobs. This study from 2023 spelled out that a traditional primary care physician to do the pre-visit direct patient care and charting and inbox would need 27 hours a day. And even with team-based care, which is supposed to be helping, this is still work that exceeds the working day. So our hope is that by bringing in team-based care and AI, that we can make this much less. So to summarize, it's about people. But we need the support of technology and information, but we need to streamline and simplify these systems. Thank you very much. So I'd like to now turn the microphone over to my good friend and colleague, Lisa Danielpour, who will bring a different perspective. Thank you.
Hi, I am honored to be here to share my perspective as a patient and family advocate. I like to start with what inspires my advocacy, which are my 2 wonderful sons. My younger son had a difficult journey with what turned out to be a rare version of Crohn's disease that started at 13 years old and caused him to be hospitalized for almost 8 months straight in 2015. We're so happy he's doing better and is a student at Case Western Reserve University, majoring in biomedical engineering. And endlessly grateful to his specialists and teams at NIH, University Hospitals, and Cleveland Clinic. I have also learned so much from my older son's neurodiversity journey with autism. We've always tried to do everything we can to support him while learning and honoring how he is wired and seeing the world through his wonderful eyes. He graduated from Case Western Reserve University and is a software engineer. When I talk about disabilities, I like to start with a piece of data. 28%, or 70 million US adults, have at least one disability of some type. I have been fortunate to be able to combine my personal and professional experiences to give back with a special focus on chronic illness, disabilities, and healthcare technology. And I'm honored to have recently become Internal Communications Manager for Case Western Reserve University School of Medicine. Now, I know the patient portal can be such a challenge and an onus for all of you. But for patients, families, and care partners, it's like a magic door. It's incredibly helpful, empowering literally with access to information, enhancing patient safety and experience, playing a critical role in chronic illness, self-care, self-advocacy, and for healthy patients to ensure preventive care. I also believe it can serve as a physician and nursing tool to coach and motivate patients. When you find out there's a chronic illness in your family or for yourself, there's so much to learn and it is overwhelming. It really feels like you lose all control. But access to the online health record can help give some measure of that control back. Messaging, which we're going to obviously talk a lot about today, for the patient provides a way to ask a quick question, refill a medication. But there's so much more. Being able to monitor lab results and medical tests, easily track trends that you're learning so much of that are issues of the disease, reading progress notes in your own time to reinforce the care plan that can be so hard to remember when you come home from a doctor's office or a hospital stay, and coordinate care across health systems. For people with disabilities, alternative technologies are so essential to many people with communication issues. Autistic individuals, people with sensory issues, anxiety, may prefer the portal messaging to phone conversations. Making a phone call can feel very intimidating. And I also share this important message that designing for people with differences helps everyone. We all know that a curb cut is really important and vital for a wheelchair user. But imagine all the other people it's useful for, like if you've got a baby stroller. One trend I just wanted to highlight that I'm seeing on the patient side when I go to send a message that I hope is some sign of how smart technology could simplify some of these processes is I'm being fed this menu that prompts me for an action that I am seeing evidence of is clearly like queuing to different teams. So even if I go to ask a medical question, sorry, it's not queuing up my next thing. Thank you. It's showing me this sub-menu that prompts me more. So that is trying to obviously tease me into, are you really just asking a medical question or are you asking something else? And what I'm seeing interestingly in the response is I rarely hear from a physician. I hear from staff, from a tech, or from a nurse. So I hope that's one small sign. The more I learn about all that you deal with every day, and I care so deeply about it, and I just want to thank you so much for all you do for patients and families every day. Next, we'll hear from my colleague, Bill Hersh.
Thank you, Lisa. My name is Bill Hersh. I am a professor in the Department of Medical Informatics and Clinical Epidemiology in the School of Medicine at Oregon Health and Science University. I started my career training in internal medicine, but many years ago, a lot before the technology we have today, found a home in clinical informatics. And that's where I've spent the majority of my time as a researcher, educator, advocate, and so forth. So I'm just going to make a few comments before we get into the details of the managing the inbox. As the advocate for technology, although I recognize its limitations and it's great to work with people who constantly remind me of its limitations, I do think we need to think back to times before the current technology we have and how our technology has been beneficial and try to find ways to make it better. For example, when I started my career even in informatics, I used to take call for our internal medicine clinic. When a patient would call me evenings, weekends, I'd be at home or out and about. There was no way I could access their medical record. I only had the information they gave me on the phone. Now, of course, most physicians, for better or worse, can pop open a laptop or a computer or a phone and look up the patient's record while they're talking to them. I remember medical records being illegible, being disorganized, missing volumes of the chart and so forth. Now, despite the fact that we still have a lot of design issues with electronic health records, they're more readable, and if they're designed well and implemented well, more searchable and so forth. Back in the old days, care was mostly limited to a person or trying to talk on the telephone. Now, of course, we have telehealth, and it's not the right solution for everything, but does provide more interaction with patients. And also the access to knowledge, which is actually the area where I do a lot of my research. Again, back in the days, I can remember having to go to the medical library, thumbing through the index medicus books and so forth. Now, of course, we all, and when I say we, I mean not only clinicians, physicians, pharmacists, others, but patients have access pretty much to the same information. We may run across paywalls and so forth, but by and large, the high priesthood of physicians only having access to medical information has long been broken down, and I think that's a good thing, despite, again, the problems of things like disinformation and so forth. So we still have problems, and they're really more related to how we implement technology rather than the technology itself. So, for example, we know that electronic health records slow clinicians down, but we're finding ways to help them gain some of that time back and achieving the other benefits such as legibility and searchability through things like ambient dictation. And the poor workflow that we've set up, sometimes trying to mimic the paper record, has led us to problems like the overwhelming inbox, which we'll hear more about in a moment. Next slide. Or am I supposed to? So one solution, and I have somewhat of a maybe conflict of interest here because I spend a lot of my time educating people, not only those who work in informatics, but clinicians, particularly medical students, nursing students, public health, et cetera. And so it's really important that informatics, as we call our field, is a skill that everyone has, even including patients. So everyone needs to know how to navigate an online electronic health record to search for and find information, using things like clinical decision support, telehealth, and so forth. For clinicians, being able, if they are users of social media, to maintain a professional presence. And so not only the clinicians, but also the informatics professionals, and again, patients also should be well educated in using a personal health record, connecting with their clinicians, finding information, and so forth. So on my last slide, I will just mention that, and you've heard this theme, that there are new technologies that will hopefully help us use the technology better and deliver more patient-centered, person-centered care. And a lot of this comes from artificial intelligence or AI, and we already see AI in use with things like generation of draft patient messages, risk prediction, summarizing patient records, and so forth. All of these are things that will hopefully not only improve care, but also help to save time. But we have to approach AI like everything else with technology carefully. For example, automation bias. We know that machine learning algorithms can read radiology images just about, if not as well as radiologists, but we need to be careful to avoid things like automation bias, where we just accept what the computer tells us without thinking about it. We know, particularly when it comes to generative artificial intelligence, ChatGPT, and all the others, we need to be careful for when those systems hallucinate or confabulate. We hopefully will have, going forward, systems that give us references to back up the information that they're stating. And we also must be very cognizant of bias, bias in the data that feeds those algorithms, and bias that results from the algorithms themselves. So we need to be very careful about the data that we collect, how it's organized, how representative it is of the population, and so forth. So all of these are things we must be cognizant about as we move to implement AI in medicine. And so now I'm going to turn the floor over to my colleague, Dr. April Savoy.
Hi, everyone. Thank you so much. So yes, I am April Savoy. I'm an assistant professor of industrial engineering at Purdue University, an adjunct assistant professor of medicine at Indiana University. I also direct the lab of human-computer interaction and simulation at the Richard L. Rodebush Veterans Administration Medical Center, as well as having a seat as a faculty investigator here at Reconstruct Institute. All that to say is I am working hard in many different places to help integrate human factors engineering. So let's talk about that a little bit, because a human factors engineer is not often the first person or the most consistent person that you've seen at these type of meetings or at the tables or meetings that you have in your facilities. My goal as a human factors engineer is to improve outcomes for patients and clinicians by integrating human factors engineering with our health information systems. Today, in particular, I want to introduce you to human factors engineering. I want to equip and encourage you to initiate and participate in human-centered designs. Real shortly, our one-liner is I want you to help us help you and your patients. That's the goal. So what is human factors? What is human factors engineering? So human factors is understanding the interactions among people, right? People and humans and other system elements. Human factors engineering is a science at the intersection of psychology and engineering. It's dedicated to designing all aspects of a working system to support human performance and safety. And it's the application of scientific methods to improve system performance and prevent accidental harm. So if you're reading through this, the word system has popped up many times, and that's key in the heart of my perspective as a human factors engineer. It's about systems level thinking. And before I talk to you more about the system, I want to talk to you more about why we need this. And I can show you framework after framework, theorem, principles, evidence, but I figured there's some other ways to do that. So I have some illustrations to bring you into this conversation and start our interaction portion. I'm going to show you some illustrations that hopefully demonstrate the need for human factors engineering. So these illustrations are going to not be related, or illustrations of direct health information technologies, healthcare systems, or policies to protect the innocent, right? And more so just so you can create your own analogies and really bring into mind what experience, what interactions pop up, and start to give your own brainstorming and ideas of your own. So I'm going to start here. The picture on your right, I think it's on your right as well, is actually of structural beams. It is in a building. It's holding the building up. Important intervention? Yes. Achieving an objective? Yes. Any other thoughts? Now think of a policy, health information technology, a workflow, any other type of aspect that may actually negatively impact your ability to complete a task, even though it is an important intervention in achieving some objective. Do you have any instance in mind where there's some kind of environmental or organizational change that may actually impact your workflow in maybe not the most favorable way? Or something that requires you to change your normal approach or routine because this has now been implemented? And I'm seeing comments in the QA in the chat. So this is resonating. You may be thinking, something is not quite right. So you learn. You say, you know what, before they do this, before the next project, I should probably talk to someone. Tell them, don't put things in my way. Is there a way for you to implement this and not actually, again, coming to my pathway? Be careful with the way you ask that or you say that, because here's the next one. It's a garage. The door opens and closes, and it's not in your way anymore. You've identified preferences. You've communicated a plan. And you've probably assumed the obvious, like it should probably be on the first floor, where your car can go, and because you focused on the functionality this time. So what this demonstrates is that while some technical or building requirements may be met, they don't make it usable for you. So again, you're thinking, something is just not right. Think about, again, something that has been implemented, something in your workflow that's giving these same kinds of symptoms or reactions that you have now. So next time we go to a project, we're going to work together. We are going to collaborate with other experts. They have different specialties. We're going to make things better. We've collaborated on the project. On the right, you see a fire hydrant. We've had 2 teams. One team was working on accessibility. We're using these common terms. They're design buzzwords. We have accessible stairway and a handrail. We have a newly designed fire hydrant, which is bright. It's noticeable. We have 2 different languages there. Definitely important. However, it's useful, but it's not usable. Can you think of anything in your practice that is useful, but not usable? Or maybe there's some data or something it's there, but you can't access it. Why? Again, there's something that's just not right about that. And that's why we're here today. That's the need of human factors engineering in this domain and in this space. Because as Bill was talking and mentioning, technology has brought us a long way. There are great advantages to it, as we heard from Betsy and as we heard from Lisa, but it has to be designed and implemented in the right way. How do we do that? From a human factors engineer standpoint, we look at the systems level. So that word system, I'm referring to this. It's the work system. That work system is bringing out all these 5 factors: technology, organization, task, environment, and humans, and showing that they are all interrelated. The problem is when we're talking about requirements, when we go to design, most often you'll hear about technology requirements. It's easy to identify and point to documentation of organization requirements, which tasks have to be done, where those tasks need to be done, in which environments. But how do we quantify and define or characterize the user or human requirements, which are mostly qualitative? When we talked before, Lisa mentioned words as, I was actually working here too, as empowering, enhancing, coaching. Betsy talked about being able to communicate trust, strong relationships. That's very hard to take to a computer software or computer engineer, computer scientist, and say, code that. Give me something that makes people happy, right? And that's where human factors comes in. We come in and we talk to users. We want to be able to understand what your needs are, what the strengths and weaknesses are in your environment, and all these other different factors, and understand what you need, what needs to be preferred, how it needs to be customized, not just implementing technology because it can be done and you have to change your methods or your approaches, but actually developing technology so that it is doing the support that the other panelists were mentioning earlier. And so in human factors engineering, we do have those measures. We do have those methods. We do have these ways of collecting the data, and not only collecting that data, but also translating it into operational requirements that can take you from problems to solutions, from actually working with technology to make situations better, to improve those outcomes for patients and clinicians. One particular way that we're going to talk about today and get into detail is the human-centered design. So as a human factors engineer, we talked that there's many different ways. This particular way is an iterative design process that is systematic and evidence-based. You'll see it can be, again, illustrated in many different ways, but it's modular and it's iterative. We start by understanding the context of use. Who's using it, where are they using it, why are they using it, how are they using it, what are the issues? We really take that time to understand what is happening. This is where we start to identify unintentional consequences and things that have these effects that won't show up in the traditional metrics of how much time this took, how many medications were prescribed, etc. Then we specify user requirements. We design solutions by prototyping and testing, redesigning, and evaluating against those requirements. I want you to understand that in our new processes and methods, these are all methods of co-design, where you, as physicians, as patients, as users, as interactors in this system, can participate and are encouraged to participate in any and every part of this design process. Today, we're going to practice, and we're going to focus on this first method, this first step, understanding the context of use. So before we get into that, as Bill talked about educating people for using technology, I want to educate you and give you the basics, the 4 principles of human-centered design. 1, it's people-centered. We start with understanding our users and our people. What do they need? What are their strengths? What are their weaknesses? What are facilitators? What are barriers? 2nd, solving the right problem. As physicians, you know, you don't want to treat the symptoms, you want to treat the root cause. Same thing here, finding out what is the right problem. And then understanding that everything is a system, meaning things do not work in isolation. They can't be implemented in isolation. There is going to be an impact on every other factor in that work system. And when we keep that in mind, it'll help us to develop better, small, and simple interventions that we can create and test, create, redesign, test, and build upon, and that enhance brings in our iterative process. So we're going to take a breather now. This is where we actually see it in action. We've been talking about the inbox problem, right? As we will talk about it in detail. But everybody has to interact with an inbox in one way, shape, or form. We're going to start right now, true to the practice and the principles, and start to ask you questions about how you define or you experience the inbox problem. And then we're going to talk a little bit more about it as the group or with the group. So the first poll question is, what are your perceived goals or expectations of the inbox? So we're going to pause and give everyone time to submit their answers, please. I'm seeing no submissions yet. Alex, I don't know if there's some instructions on how to submit that or to make sure people, now they're coming in. Thank you. Okay, they're trickling in. I know we have a couple more. So let's give it a couple more seconds and then we can show the results. Okay, we can show the results now. So we have the majority of people saying message management and tracking, with the second expectation or goal denoted as patient and clinician communication, with the third being clinician and clinician communication. Thank you. I'm going to go to the next poll. What type of emails are most prevalent in your inbox? Is it patient emails, lab results, referrals, duplicate emails, non-important emails, or you have no idea what's in there? Please take your time to answer, or take some time to answer and submit responses. Great, I see a break in the submissions. Can we go ahead and show the results? So most of the emails prevalent in inboxes right now are lab results. And take that into consideration, panel, when we're discussing, because those lab results, one of the questions are going to be, are those actually in the EHRs already? So is that duplicate information? The second percentage is patient emails. And followed by non-important and I have no idea, which is very telling and a great response. And lastly, what is the most frustrating aspect of your inbox? Is it the number of emails, the repetitive steps to manage those emails, or lack of filters? Is it its interruptive or distracting nature, or something else? Please take a couple of seconds to submit a response. Great, and we can show those responses now. The number of emails is 66% of the responses, followed by lack of filters. So that sheer number is actually what's most frustrating, which I think is corresponding and in line with what our panel members were talking about in previous meetings as well. So with that said, let's talk a little bit more about those aspects of the inbox problem. And we're going to do that in a shortened, abbreviated design interview with our panel representatives. I'm going to keep this slide up. Okay, so let's talk about those poll results. Betsy, I think you were the one that talked about the sheer number of emails. I'll ask you first, how much do you think is too much? And then we can ask the rest of the panel.
Well, you know, I think the day should fit within the day. And of course, we have all the other stuff that we're supposed to do during the day. So I think I kind of pared it down to kind of, it's almost like a federal investigation. Who needs to know this information? Why do they need to know it? What do they need to know? When do they need to know it? And how should it be relayed? So for example, a phlebotomist may be so excited that they can send a primary care physician a notice that the patient came to get their lab drawn, but the physician knows the lab was drawn if they receive the lab result. So the ability to send your patient got their blood drawn is not helpful from my perspective. So I think each person working in the system needs to be able to identify which information is helpful. So for example, I would like to see the labs that I ordered, but I don't want to see the labs that every one of my consulting colleagues ordered because it's confusing about who's actually supposed to manage it. Whereas if the lab returns to the person who drew it, it becomes their responsibility. I also don't want to find a critically dangerous lab at 11:30, 2 days after PM, 2 days after it was drawn. When something's really critical, that's a person-to-person communication, and you need to close the loop by saying, I spoke in person to somebody, not through the inbox, not through a secure chat, not through their personal telephone. So I think we need to be thinking about the information and who needs to get it. And the duplicate information is not only distracting, but it's dangerous to patients because it confuses who is supposed to act on the information. And the information is already in the EHR, so it's duplicative.
Right. From the patient side, Lisa, how do you feel about having too many emails from the healthcare system? Or do you ever have that experience?
Well, I think the answer is yes. Patients can get, and family members, anyone who's a proxy can get a crazy number of emails, and we may not realize, here's a design issue or a user issue. We may not realize that there's usually a way we can control some aspects of notifications, like, oh, I feel overwhelmed. I'm getting a text, an email, and a voicemail or a phone call when I probably don't realize that there was some default set at some point in the portal that is setting this up, and that I can, control that. So I think that's important. I just wanted to also I love what Betsy said, and I would just also say that prioritizing critical results in prioritizing emails is a really important thing. Speaking as a family member who's gotten that phone call that, the hemoglobin or the whatever is way off, and I'm really sorry, but we need to get, so-and-so to the hospital. So I think that's an important issue as well.
Great, thanks. And yes, I agree. It speaks to the importance of intuitive design and good education, which brings me to Bill. You were talking about the use of technology in training people to, and I'm going to use the wording from a question from the registration. How do we tame the inbox beast? Noting the technology filters or features that you have seen implemented or designed, how would you teach, or what would you share with everyone today?
Sure. Well, I would go back to, some of the things that Betsy and Lisa said about, thinking about how do we control the flow of inbox of things that come into the inbox. This isn't really a clinical example, but it's something I deal with all the time, being very active in email with people I collaborate with, is people replying to all when they don't need to reply to all. In fact, some email lists get that set up by default, and you have these conversations, or someone says something and then you get a second email saying, oh, I'm sorry, that was just meant for so-and-so. I think it's, again, it kind of goes back to implementation, and implementation is, comes from education. We educate the informatics professionals to, do what they can to minimize the excess email and other messages that get sent to people. We educate clinicians. Again, to Betsy's example, we say that, sending a critical lab value at 11:30 at night, is not really the appropriate thing. It may be, calling someone, calling the physician on call or something like that. So I think thinking about, being thoughtful about the design of how emails are sent is really critical.
Great. And here's another question that everyone is talking about with AI. AI can come in and maybe help us with this problem. For everyone on the panel, if you had the ability to create or design your own AI to help with whatever feature would be, how would you envision, or how would you hope AI would particularly help you with your inbox problem?
Well, since I brought up AI in my slides, I guess I can answer this one first. I think it, again, kind of comes down to, what is the most appropriate use of AI? We're all enamored, myself included, by the real sexy uses of AI, answering clinical questions, reminding us of rare diseases that, no one thought about. And those things are great, but it may be that the better use of AI, at least initially, is for more of the simpler things, that aren't quite as sexy. For example, one application which some of the commercial electronic health records are implementing is drafting responses to patient questions that come in. And I emphasize the word draft because there needs to be a human in that loop. But, maybe the system can, suggest the answer to a question, and then the physician can go in and customize it for the specific patient. Again, things like, ambient dictation that make charting go faster, but don't necessarily, answer all the complicated questions in the world. So I think using AI appropriately.
Betsy?
Yeah, I think if we can kind of imagine all the stuff we do with Siri or Alexa or another virtual assistant in our lives, we can imagine that if you could, at the end of a primary care visit, say, could you kindly refill Miss So-and-so's standing medications and put in a prescription for amoxicillin for 10 days with no refills at 500 milligrams? Could you kindly copy the SSI form from last year, leaving a signature and date for today? Could you kindly produce a letter for a 4-pronged cane? And if we did that stuff, it would give us a whole lot more time during the visit to be actually interacting with our patients. And I hope that you have a patient, you have a practitioner, you have an EHR, and that AI can form a fourth point in that tree, hopefully helping make decisions, find information, and do rote tasks that are taking up so much of our time. And that will free up docs to do more. I'm going to put into the chat a video that was made many years ago, but is a really lovely example of what this might actually look like in a doc's day that you can take a look at later. It's about 10 minutes long.
Thanks. And Lisa?
I wonder about, in addition to the other points, using AI in terms of the email as part of the filtering process, that it sounds like is an issue for practitioners, physicians, to just help with that and customize it. I love the example of whatever I would use for Siri. I will say on the patient side, and maybe thinking about this, like as Betsy articulates these beautiful things about how it could be integrated into the visit. One thing we do is use AI to take a complex terminology or issue and put it in and say, and ask AI to explain it to me like I'm, a middle schooler. And, there may be ways to help with patient education through those kinds of tools. Again, of course, with the caution that I do find AI will improve over time, I'm sure, but it does give you some odd answers that are not necessarily true, the hallucination issue, but I think there's a potential there.
Great, great. Thank you. And so I want to take the time, and I'm looking at the time, right? And really just ask our audience to reflect on the conversation we just had. Were you able to answer any or all of those questions? Did you have experiences or other things that you could have added to the conversation? You probably did, and that's a design interview. You are talking about your experience, your interactions, and no one knows that better than you. And that's the data that we are collecting up and observing. So from that, if you could see my desk, I have notes all over. The human factors engineers can come in and start to apply what we just talked about and start to identify. So you see the little explosions or potential hazards or errors with what was actually described. There was some organization issues and potentials there with policies and how they use it, how it's a scolding, punitive nature. There's tasks. We talked about lab results being using the inbox at that late time. That's a potential problem for that particular type of task. And then we talked more about a lot of technology issues and design improvements. So it starts to show which particular factors should be prioritized when we're doing problem solving and we're trying to figure out where the design interventions need to happen and what aspects need to actually be prioritized and attacked first or designed first, addressed first. And that would take us to, remember, we only did the first part. We're only starting the first step of that design process, but that would help us to start looking at and developing, drafting even our design user requirements. So here we started to characterize what was just talked about. The frustrating nature, the overwhelming nature, the time consumption, the unorganized nature of inbox, but also the good points as well as it has a communication history, it's empowering, and it can increase awareness. So taking into consideration both the facilitators and barriers helps us to have a better understanding of the context of use. And then we can start to create these preliminary design ideas that you just heard from the panel. Maybe some defaults to setting minimum organizational requirements, real-time filtering capabilities. There was some talk before about, and maybe this is where AI could help with escalating or triaging the messages so we have a better, more manageable number of emails as they come in, distinguishing between what's just a notification and an actual message with content that needs to be opened and read here. And then customizing settings for inbox management that may include automatic deletion rules based on time, opening of other team, or opening by another team member, using that team-based usage to kind of help us better manage these inboxes. So again, there's different ways that we go through taking just what you talk about or observing you in work and translating your experiences and your perspectives into these metrics, these measures, these requirements that are needed to present to leadership, to present to our teams for software development and implementation of new interventions. We didn't do it here today, but this is just an example. We have gone from using design interviews and simulations that were actually based on the current use of, this is a template for a referral to rheumatology, and going from this template on the left to a template on the right that actually did include some low-level AI, some automatic entries, pulling of results, bringing information in together so physicians didn't have to go around and find some information here, retype it there. It saved time, it used the information wisely and became more efficient. So we can go from ideation to implementing designs that are human-centered, and that actually, again, goes back to supporting our patients and our clinicians and improving their outcomes. So with that, there are some engineering, some impacts and benefits for quality, understanding clinician practices and patient needs for better experiences and improved outcomes. Safety, we can identify potential errors and redesign systems to mitigate hazards, ultimately improving patient safety. And efficiency, examining work processes to improve performance and productivity. I want to thank everyone, but I also we do have time for anyone on the panel that wanted to give a quick one-liner or summarization for, from their perspective in the process. Please take this time now. They're silent. Okay, well, I will turn it over to you, Laura. Thank you, everyone.
Thank you. I think we have time for maybe a question or two. A couple questions that came in on the registration. There was some about the inbox, which we just chatted about, but I just want to do a quick promotion for SUPS Forward is now going to be launching these learning collaboratives. And the first one is going to be on in-basket reduction, optimizing and managing the in-basket to reduce work burden. This is a chance to meet with AMA physician experts that will be kind of walking you through this. There'll be 4 webinars, and I think they'll go 3 to 4 months. And there'll be designated office hours for consultations and assigned homework for participating groups. So just wanted to plug that as it's relevant here. Feel free to scan the QR code. But I think we, as I said, have time for maybe a question or two if anyone wants to plug them in the Q&A, and we can ask our panelists.
And while they're doing that, there was a request for Bill to say a word about communicating this with administrators.
Yeah, can you provide a little bit more communicating with administrators?
I think it's how to actually take what we've learned today and the findings that we have and try to influence administrators to actually use them or implement change, maybe change management.
Sure. No, I think, leadership in healthcare has to, in some ways it gets back to what Betsy said about that it needs to be more about relationships than transactions. And so leaders in healthcare, yes, the bottom line is important, no money, no mission. But on the other hand, as our organizations deliver healthcare, we must be cognizant of the impact on patients, on clinicians. So, and that will take professionals, clinical professionals, informatics professionals, other, professionals, design human factors professionals, and so forth, to try to figure out the best ways to do these things that have the maximum positive impact.
Thanks. So I hope we've encouraged you to reach out and to start these types of initiatives in your own system and healthcare facilities and be empowered by that process. Laura?
I have one question here we can do quickly. Sometimes it feels like technology is meant to make things faster so that we can produce more. What is the true role of technology in our patient encounters? And this came up, as we think about ambient listening and saving time, the clinicians are saving time. Who's benefiting from that? So what does that mean to work faster and produce more? What's the true role of technology in patient encounters? And that's for anyone.
I give it to Betsy.
Our patients are older, they are sicker, there are more treatments to do for them, there are more sources of information, there are more ways to try to make the right decision. And so it actually takes longer to do all this work. But a very interesting study came out of the United Kingdom earlier this year. I think I have this right, 318 practices, 11 years, more than 1 million visits. And what they discovered was that when patients saw their own physician, The visits were longer because they covered more issues, but the patients needed to be seen less frequently, and so there was actually more availability for the primary care workforce. But when patients saw the PRN doctor, the urgent care doctor, came in to see somebody they didn't know, they got one thing taken care of, and then they were punted back to their own physician. And so 1 million visits later, it turns out it's a good idea to see your own doctor, and that continuity of care is a real thing, and that it not only takes better care of patients, is more satisfying for patients, but it actually makes more availability in their schedules. So I think that's a really, really important concept to think about.
I agree. And I would say it's not about faster. It is piggybacking off what Betsy said and what we do in engineering. It's about efficiency, effectiveness, and satisfaction. So that efficiency is not necessarily just doing it faster, but are you actually doing what you need to do and not taking up too much time or wasting resources or patients' time and effort.
All right, well, we're at the top of the hour. I want to thank you all so much for joining, and thank you so much to our presenters. This was just such a great session. Everyone have a wonderful day.
Thank you.
Thank you.
Thank you.